Good afternoon, everyone. Thank you so much for taking out time for joining in for the webinar. We will be playing a short video about MedLearn. Thank you.
Hospitals work round the clock to serve patients. Being at the center of the action, hospital physicians and staff must confront every situation and every challenge. They must also keep up with evolving health needs and knowledge through ongoing comprehensive training programs. What they need is a promising solution to ensure a continuous learning journey.
In today's world, technology is transforming life. Be it taxis, food delivery, everything we need is at our fingertips. Education is also going through a transformation, and we are at the forefront in the healthcare industry.
MedLearn is a comprehensive learning, training and skill development platform incubated at Impel-SIS in India for healthcare professionals to attain the right mix of content, learning and skills that help them throughout their career. The platform offers a wide variety of courses that enable hospitals to meet their employee training and development needs in areas of quality compliance, soft skills and induction. The platform is designed in a way that it enables easy tracking of the real-time status of their learning progress. What's unique about this platform is that it's accessible anytime, anywhere, ensuring quality learning literally at your fingertips. Hospitals can now assign courses and track the competencies of users on specific topics with MedLearn's intelligent assessment tool, which gives them better administrative control. Its superior courseware helps hospitals provide standardized care and bridge skill gaps at every level in the organization. The healthcare professionals will also become more efficient and empowered when their learning journey progresses with ease and at their convenience. Let us unite to improve healthcare in India by spreading knowledge through technology. MedLearn. Better prepared for better care.
We just have one more video coming up on NABH 5th edition. Good afternoon, everyone. Our our first speaker for the day is Mr. Varun Kumar, Head of Business Development, Medlearn. He will be taking us through a short introduction about Medlearn. Varun, thank you so much for taking our time. Over to you.
Thank you so much, Richa. Thank you so much also for sharing those two videos, one about our corporate video and also the latest video on the NABH. We have recently launched our training modules on NABH 5th edition. I think we have our guest, Dr. Madhu, and who will be going to speak on this very interesting webinar, which is, from being compliant to committed, to primarily be focusing on what's there and what has changed in the latest NABH 5th edition. But before I hand it over to Dr. Renu, who will introduce Dr. Madhu to start this webinar, I thought maybe I'll take a couple of minutes, maybe 5-7 minutes, to talk about what is Medlearn. And we have just seen the video. Medlearn, a better prepare for better care, is on a mission to change the healthcare in India and Asia by lifting the quality of training and the skill provided to the healthcare workforce, right? And it resonates with our founding belief that the quality of care can dramatically improve when the hospital invest in their most valuable asset, which is their employee, primarily the nurses, technician, paramedic staff, of course, the doctor, which are all the front line, by giving them the access to best-in-class learning experience of global content, which is just not good for the compliance or the reducing the risk of errors, accidents, infection, and compliance, which is also good for the hospital business and for the society as whole. Medlearn, as we speak, we are in about 160 hospitals serving more than 44,000 healthcare professionals who are getting benefited through our digital platform, which is made for hospital. But our goal is to reach into 5,000 hospitals by 2025. And by then we will be serving 1.2 million healthcare employees, the students learning on our platform by then. Our promise to the healthcare sector is three things. That one, we will bring the world-class evidence-based knowledge, skills and learning experience to hospital and healthcare workers at an affordable price, which is important. Two, we will help the hospital meet in today's challenge of compliance, risk management, and the operational efficiency. And three, we will also help hospital successfully delivering the tomorrow promise of being a better care outcome or the patient experience, or becoming the trusted brand. A bit about Medlearn journey in India and Asia. As you can see on the screen, you will know all these brands. It needs no introduction. And I reiterate that Medlearn is going to be a complete learning ecosystem for Indian hospital and healthcare professional, right? It's a cloud-based platform that is deployed in 160 hospital and 44,000 healthcare professional. Quickly, diving into the Medlearn, which is a cloud-based platform. What all it offers? So at the core, it's a comprehensive learning management system. It helps you in your compliance and certification processes. It's a mobile-ready solution which allows your workers, your staff to learn anytime, anywhere on their phone, and not get bogged on getting into the classroom trainings in the hospital. Anyway, that got disrupted in today's time. The feature of Courseware Builder allows the hospital to create their own e-learning module on the fly. And we hear this from a hospital that they have so much of their SOPs, training material, module, induction training, department specific training. All of that can be converted into e-learning module and be delivered through the Medlearn platform. Yeah. We've added recently a new feature, whereby Medlearn allows you to conduct your virtual classes and webinar. So no more hassles that, okay, if your training been disrupted, how you do it. Medlearn, offers you that solution, by conducting those classroom sessions online on the Medlearn platform. Talent assessment is another piece which we have introduced, whereby it allows you to create your exams and deliver those exams, so that the hospital managers and their operational head can, on a regular basis, check the cognitive and the competency level of the staff on a regular interval. It also allows you to rather helps you in your hiring processes by reducing the screening time, by evaluating your candidate wherever they are. They don't have to come to your premise, right? Very important piece on which is available on Medlearn is the training management system. What it allows you to do is it allows you to create training programs, specific training programs on the need basis of your workers across different departments, and you can run all that program on a digital platform, on Medlearn. And last but not the least, with insightful reporting, analytics, it gives you a clear-cut view, a bird-eye view, always at a click of a button, that who is doing what at any given time, whenever you need those reports, right? So overall, a key value proposition that what Medlearn offers is the technology, which is the world-class mobile-friendly solution, the learning management system at the core. 2, we provide you the hospital-specific workflows. I just talked about this, how Medlearn is doing those, thereby streamlining some of your inefficient process, and thereby improving productivity by all this, features like communicated training management system, assessors, and the reports. And the third and the very important piece is that we also provide you the valuable industry, healthcare specific content, be it the NABH, the induction module, the emergency induction module. Dr. Madhu is going to talk about the 5th edition NABH module in detail in the next 45-50 minutes. But we also provide you the CPD programs from the prestigious Royal College of Nursing institution on our platform, which is available. What's coming up in the next 9 months to a year, we will be able to give you, the Medlearn will be able to provide you the BLS and the ACLS training, like how it is happening in the Western countries, through the platform, and no more visiting to a nearby authorized centers to get your ACLS BLS certification. So overall, it's an end-to-end training, a learning, a platform for your hospital staff. Bit of a content, what Medlearn offers. I talked about the induction training module. So Medlearn offers various range of courses, be it hospital emergency codes, hospital safety, patient safety, or hospital infection control. All of that is readily available. These are small e-learning module, size, ranging between 30 minutes to 40 minutes. The idea is to inculcate a habit of, self-learning, instructor-less learning, and learning on their pace. Yeah. Some of the soft skill courses which are available on the platform as well through Medlearn. These are all third-party courses, but then again, it provides you the soft skill which you need, and thereby training your healthcare staff with the right skills, giving them the confidence to handle all kind of challenges at the workplace. And third and last but not least, the quality compliance modules. Medlearn also have ready, modules available which covers all. Both 4th edition and the 5th edition, and 5th edition again, Dr. Madhu is going to talk about. Before I hand it over to Dr. Renu, a little bit about the parent company, Impelsys. So Medlearn is a subsidiary of Impelsys, which is a global leader in the STEM learning. We were also the first SaaS platform for the ebooks and the e-learning segment. 2 decades of experience of serving medical content in the learning provider. We are very proud to be associated with American Heart Association and Ladles for their BLS and ACLS programs across the US hospital, the thousands of hospitals, and serving millions of learners on our platform, right? And the last slide, which I'll leave you with, these are the, some of the trusted relationship which we have built over those 2 decades. You can see all those names, right, from ASCO, AHA, Ladle, Walter Cloovers, Thyma, Alcivia. So, but before I hand over again, you've heard about the Medlearn as a platform. If any one of you want to see a demo, please do write us to at info@medlearn, info@medlearn.com, or just simply call this number 888-492-8866. Yeah. With that, I won't take much time. Dr. Renu, over to you.
Thanks, Varun. Good afternoon, everyone. As you are all aware, NABH 5th edition was released in April last year. And since then, the organizations have started preparing for transition into the 5th edition. Now, there are a lot of queries that come regarding the 5th edition from our hospitals. And through this webinar, we are trying to address some of these queries related to organization preparedness, audit preparedness, the scoring system, and what to expect while implementing the 5th edition in your organization. Now, without wasting time, I would now like to introduce our speaker, Dr. Madhu Malathi. Dr. Madhu is the CEO and the founder director of Medla Healthcare. Dr. Madhu has executed more than 50 hospital consultancy projects, both in India and outside. Dr. Madhu has been involved in commissioning greenfield multi-speciality and tertiary care hospital projects in compliance with both NABH and JCI standards. She is an internal auditor and also a domain expert. She has developed hospital operational training content. And Dr. Madhu is also a key participant and a knowledge partner with ISBR Bangalore for their postgraduate hospital administration program. Welcome, Dr. Madhu.
Thank you, Dr. Renu. Thank you so much. Thanks, Varun. Thanks, Richa. And thanks, Dr. Renu. I hope the screen is visible.
Yes.
Yes, let me just change it over to the slideshow. Okay, good afternoon to everybody present here. So today our topic is on the organization preparedness for 5th edition NABH. So rightly said, the tagline there, which says that quality improvement from compliance to commitment. So that is what we are going to be looking at very briefly, because this again an extensive topic by itself, but then we will just try to cover it up in next 40 minutes or 45 minutes. So as we are talking about organization preparedness, so let me just, on behalf of everybody, let's express our sincere gratitude to the healthcare professionals and the workers who have been consistently working remarkably good, covering up during the pandemic period and still carrying on. So in the next 40 minutes, the way we're going to just have our agenda placed is a very brief introduction to NABH 5th edition, and then we'll just also look into the chapter-wise salient features. Then we will move on to the organization preparedness for either adoption or migration, then the audit preparedness, and we would want to call it as a last slide because quality is just a continual journey how we intend to focus on. So that is how we intend to cover it up. So quickly, NABH 5th edition came into effect from April 2020, and the healthcare organization, HCO, either adopts or migrates with immediate effect. So that's how the indication from the Quality Council of India or the NABH body we got. So that's how the organization is going by. So since April 2020 and much prior to that, when the draft document was released, the way the preparation has been going on. So at this point of time, we all are well aware it's a 5th edition which is in place. Few of the organization are already accredited with or adapted or in the process of migration. So it's already a buzzword is already there for the 5th edition NABH. So, but nonetheless, we'll try to still summarize all the activities, what is indicated, and we go by as per the agenda. So having said that, the key highlighting features towards preparedness by an HCO are, number one, it's a rightful interpretation in the 5th edition. You're understanding the standards, the objective elements for implementation. The second is, again, the effective monitoring of the objective elements. We have various categorization of these elements. So there is that effective monitoring which needs to be happening across the accreditation cycle or during the process of adopting or migration. And most important is that consistency and accuracy is in demonstration of compliance needs to be very much adhered to all through the period of accreditation and post that as well. So, and quickly, the other highlighting feature can just be on the categorization of objective elements. We'll look into it all through our presentations now. There are core elements, so, and then the commitment, objective elements, this achievement and excellence. So how we just go about in this accreditation cycle, that we will look into in our successive slides. The certification audit process, that's also another change what has come up in the 5th edition. So it's more, the audit process is more objective rather than subjective, taking away all the ambiguity which is to be there with the 4th edition. The ambiguity could be by the healthcare provider side or by the assessor side. So here what is happening in the 5th edition is it's become more objective rather than subjective. And the scoring system also, it is instead of 0, 5, 10, now it is just like going across 1 to 5, right across, interpretation is to no compliance to fully compliance. And the sample, the sample compliance, the evidence practices, whatever needs to be demonstrated, it's against a sample size. So that's another highlighting feature, what the 5th edition is coming by. And there's a lot of focus on the patient safety and the quality improvement. So to that much an extent, in the 4th edition, we had CQI, the Continual Quality Improvement as a chapter. And now that simply changed over to PSQ, that's patient safety and quality improvement. So in short, it is just that, as the tagline was indicating, it's more than the compliance, it is the commitment what an HCO has to demonstrate right from the stage, they commit to be accredited. So that is how it goes by. So the presentation slides may look a little bit of text intensive, but what we will just look into is as points. And then our focus area should just be more from the implementation or the operational activity. So having said that, this is a summary. This is a brief summary on how the standards and the objective elements are shown. That is, we have got about 100 standards and 651 objective elements. And I'll just move on to the next. 1 second. 1 second. Okay. So now we go to the next agenda point. That's on the chapter-wise understanding on what are the changes, that's amendment, and what are the new additions which has come into the 5th edition. So simply, if you just go on looking into each of these slides, which indicates the chapters, the green font indication is the new additions which has come by, and the black indications is just, these are the objective elements which is there and which has gone in for a minimal or a partial amendment. So the bullet points are as against the objective elements indicated. So this is how all the slides across the chapters goes by. So in the AAC chapter, what is that we find it as an amendment or an addition is the departments, apart from the organization scope of services, the department scope of the services also needs to be demonstrated. So initially, the 4th edition, we saw this department scope of services indicated in the ROM chapter, but in the 5th edition, we are seeing that in our first chapter itself. So needless to say, it has to be bilingual, displayed, and not just a brochure format. And we also have an objective element which emphasizes on the special needs at the time of discharge. It needs to be very specific in nature and specific to the clinical condition. And most important, it needs to be mentioned. So what are these special needs? These special needs are basically, it could be age related or mobility restriction related or a clinical condition related. So what we have to do is, though we would actually assess during our initial assessment, we would capture all the special needs of a particular patient. We carry through the reassessment phase, but most important is this objective element emphasizes at the time of discharge as well, that it needs to be mentioned and it needs to be educated to the patient at the time of discharge. So that is where the emphasis is more on the special needs, ensuring continuity in care. Then we have another objective element, which is just coming new on formation and defining the functions of a clinico-pathological and clinical radiological meetings. And this is exclusively to address the interactions between the care providers and the diagnostic team members. Though it used to be on an ad hoc basis and it used to be there prior to also, but now the emphasis is more that you need to demonstrate it. Prior to demonstration, you need to document it. So the clinical pathological is more towards your histopathology reports. So either pre-operative or post-operative, you need to, we can just pick up there is a committee which gets formed towards these regular meetings. And these regular meetings are comprised by the care providers and the diagnostic team members. And they take up these cases to ensure that the care plan is going on in line with the diagnostic features as well. So, and the clinical radiological meetings is more towards your CT scan and MRI. So that is where your emphasis is more towards defining the care plan or a multi-speciality or a multidisciplinary care management process. So we also have another objective element wherein we know it good that on the critical value alert system, though there was previously any of the diagnostic activities, we have a list of critical values, both in a diagnostic lab and in your radio imaging services. But then it used to also be given an alert indication as and when a critical value is encountered. But what 5th edition says is that it is just not only a mention of it is needed, but you take it across to the action taken by the concerned team member. The concerned team member is your care providers. So hence, what you do actually out here is you look into, once when an alert indication is encountered and captured, you also just look into in what ways you just amended or corrected your care plan, including your medication management and things like that. So there has to be an evidence which needs to be demonstrated, not just in an alerting a value system, but also how it is captured into the patient record and how it is demonstrated on your patient monitoring process as well. So we also have another objective element, which is on the discharge planning process. So the discharge planning process, the organization, the HCO should aim as much as possible to minimize their unplanned discharges. So to that much an extent, yes, you define the HCO defines the time frame and all the planning process, what needs to be carried on. Usually it's 24 hours across the various stakeholders. It can be your various multidisciplinary care providers, your pharmacy, your administrative departments, and your paraclinical services. All of these people will participate in the discharge planning process, and hence you give a time frame of at least 24 hours, which needs to be documented, and you monitor it, and you also just like analyze it as a data capturing, so as to improve your benchmark timings, whatever is needs, whatever is benchmarked by an HCO. So that is what is covered up in AAC towards amendment or an addition. We go to the next chapter, that is care of patient, COP. So here we have captured few points which is coming as an amendment. So we'll quickly look into. So the bullet points are the respective objective element. So 1B talks about patient identifiers. It's emphasized across all settings. We had this in the 4th edition, but then the emphasis here is across all various, the patient identifiers. We say that 2 identifiers uniformly need to be looked into. It's not only each time a care provider looks into, but also at the various settings. The settings can be your diagnostic services, could be your physiotherapy and your blood transfusion, your operation theater. So wherever the patient goes by, the patient identifiers needs to be captured. So, and that needs to be demonstrated in your written documents as well. Then next point is on the clinical care pathways. So clinical care pathways, depending on the organization's scope of services, what it intends to offer and the various specialty services it provides, we define this is again going towards uniform care of patient services, what we intend to give. So if you have to ensure uniform care, it's better that we also look into the clinical care pathways, specialty wise, and we look into these, review this periodically. So to that much an extent, yes, a multidisciplinary or a multi-speciality approach needs to be planned so as to bring out the best practices in the patient care delivery process as well. So we have another objective element which emphasizes, especially in the A&E department, that's accident and emergency department, wherein it focuses on a laid systems should be there by an HCO, a defined system, which is calling in for a strategies, what you want to do for prevention and patient overcrowding management. And this should also work on to include the anticipated crowds as well. So this needs to be documented and it needs to be practiced. So hence, to that much an extent, the organization can look into how, what's the time, usual time, the more the footfalls of the patients coming by. And especially in A&D, we are not only looking at the patients who are coming in, we're also looking into the, the bystanders, the relatives and all coming in. So hence, you need to have a system in place wherein you will define how you prevent the patient overcrowding system also. And it also can just go towards your patient management, your triaging system, what's the time limit you give there, and how do you just like assess them at various categories, and how you just like ensure the diagnosis services and the pushing off to the other department, critical or however you would want to, or discharge also for that matter. So the complete prevention and the patient overcrowding management system needs to be defined and adhered to while in practice as well. Then we have another objective element, which is on the patient reassessment. So patient reassessment is especially for those patients who are placed in a waiting area due to non-availability of beds. You will still ensure it is the same care services are provided. So hence, to that much an extent, a reassessment record needs to be captured also while the patient is still waiting. The role responsibility of the CPR team should be well defined, informed, trained on regular basis. And then the code blue alert system. So here the emphasis is more on the availability of the necessary medication. It needs to be there at the nearest nurse station or in the crash cart. So we'll have to look into all of those things, which should be needless to say, each of these points, whenever we are just like talking about and discussing, the focus is more towards where and how and when we are just like, preparing ourselves towards readiness. And we also have this nursing clinical SOPs. We have to relook into it and then ensure that the best nursing practices, updated nursing practices is captured in the SOPs, what we intend to implement in our training programs and also in actual events as well. So COP 6D talks about, this is an important point, which in 5th edition it's come by, which is talking about the nursing staff duty allocation should be planned and based on the right distribution and competency across various settings. It simply says that your duty roster, the duty roster has to be well planned to ensure that the competency, you have your senior nurse, you have your staff nurse, you have your nursing training, and you have your various settings, your critical patients distributed across your ICU, HDU, and things like that. And also, depending on the critical clinical conditions, you also have your patients distributed across your IP area. So what we have to do is it ensures that the duty roster is appropriately managed to have a right distribution based on competency. So it's just not only the number, the competency of the nursing staff also plays a critical role when you're planning up your duty roster. So that's a point which needs to be highlighted whenever we are defining that, and it need to be evident. So the best practices or the treatment guidelines across your other care of patient standards, which is on HDU management or ICU management, anesthesia administration, the surgical procedure management, all of these standards right across infrastructure, your technology assistance, your competency of human resources to the documentations, your infection control practices, your quality assurance, all of these scope of work against each of these departments indicated, it needs to be adhering to the best practices and needs to be updated. Then we look at 8H, which talks about quality assurance in the blood bank. So whether you have it as an in-house service being provided or you have an MOU with an agency, external agency, you still ensure your quality assurance indicators are clearly spelled out, either in practice or in monitoring, if it is against an MOU with an agency. So the other addition here with care of patients, COP16 is your high-risk patients should be managed in similar lines as vulnerable patients. So your high-risk patients could be those who are prone for fall or prone for developing deep vein thrombosis or a pressure ulcer. So we need to identify these patients, categorize them under high-risk patients, and the rest of the management protocol, call it repeated reassessment or your consenting protocols, all of this needs to be well adhered to in similar lines as if you were taking care of a vulnerable patient. Then we have last but one on the COP, that's on the scope of rehabilitation. The physiotherapy and the rehabilitation services, it needs to be well defined. It's no more just a physiotherapy. It is just also a physical therapy and a rehabilitation, which can encompass across your occupational therapy, your speech therapy, and your psychology, including clinical psychology. It needs to be, so you need to define a scope to what an extent your physiotherapy department or the physical therapy department is functioning. And then accordingly, you just define your protocols for adherence. And COP20B talks about end-of-life care management. So here again, the emphasis is a multi-professional approach to that much an extent. Whenever you're just providing counseling to the family members, it will be those respective professionals who will be providing counseling during the end-of-life care management as well. So all of this is what we look into mainly. These are highlighting points. So this is covered up in COP. We move to the next, that's management of medication. So management of medication, yes, it's a multidisciplinary committee which needs to actually look into towards defining the policy on medication management policy and the processes. So how they need to update themselves is by looking into the latest literature review and the best practices. So this multidisciplinary committee will be entrusted with the responsibility to, on a regular basis, look into what is new and how they should just work on in the management process. So that's on the broader level. But again, going down to the stepwise indication, the communication systems within the organization on pharmacy services to the end user needs to be well defined. And who are these end users? It's not only the doctors, but also your nurses, your sub-store management, your vendors, whether internal or external. So all those communication system needs to be well in place, defined, practiced, and demonstrated as well. Then we have this updated formulary made available to all clinicians. So we need to ensure that we have a customized formulary for the particular organization based on the services, based on the specialty of specialists available with us. So we have this formulary either as a hard copy or as a soft copy. It needs to be made available to the clinician, and we ensure that it's an updated formulary which will be just made available. So then we have this high-risk medication. You call it your look-alike, sound-alike, your narcotics, your psychotropic, your chemotherapy, or your concentrated electrolytes. All of these high-risk medications, we need to have a system to define a storage protocol. And this storage protocol is not only just at the main pharmacy center, but also at your sub-stores. It could be your ICU, it could be at your OT. So the protocol, whatever is defined as standard for storage of high-risk medication, needs to be demonstrated at all these settings. It can just be at the various, to the ward also, in the ward management also. So wherever you're storing this high-risk medication, it is the same principle we follow as standardized practices. Then return of medication to pharmacy. So we need to, an organization will define, the condition or the list of medications which can be returned to the pharmacy. Again, keeping in mind that because some of the medications will have temperature specifications and things like that. So apart from just only looking at the look factors of how the medication's condition, you also look into the various other factors. So hence, it is important the HCO will define which are the list of pharmaceutical stores which can be returned back to the pharmacy. And next point we have that we need to address, this is an addition that we need to address the preventive measures like tubing misconnections during medication administration. We have this, during our patient care services, we have this IV line, we have the Ryle's tube, we have the drain tubes. So we need to ensure a proper, we prevent, we just define some systems wherein we don't want to encounter any misconnections. So how do we do that? We need to demonstrate that. So that needs to be listed down. So though the designs of all of these tubes favors in minimizing or not letting any errors to happen, but then having said all of that, the organization will still have its own work instructions or an SOP on how they will just have their preventive measures defined and practiced as well. So then we have in MOM 8, we have all of these errors like medication management errors like the near miss, adverse events, and all of this, which are usually captured as an incident report. So we look at this and then we adhere to the incident management protocols, call it with time, call it with the way we look into it, who will address, how we capture all the information, then leading up to the corrections, corrective actions, preventive actions, all of that. So that is how the medication management error management will be documented and adhered for implementation as well. Then there is this, in the 5th edition, what has happened is the narcotic, psychotropic substances and radiotherapy medications. These are clubbed under MOM 9. Initially in the 4th, we had this as 2 separate standards. Here it is clubbed. But then having clubbed, the other aspects like your storage, usage, storage, administration, and the disposable practices needs to be well defined. And we just have to adhere to the same, whatever is defined. Then the last objective element under MOM chapter is on the 10E, which is on the recall implantable prosthesis. So when do you recall either internal feedback or a manufacturer's recommendation? He will provide you an indication for recall, or it can just be the authorized regulatory body. So from either of this, whenever we get a recall indication, we need to have a process wherein if it is from a regulatory body and from the manufacturer, what is the system you will follow? Or if it is an internal feedback, which is indicating for us to recall, how is the information you would provide to the manufacturer and also to the regulatory authority, that needs to be defined and implemented. I mean, whatever you need to define, which is simply a written guidance, and these written guidance should lead us towards implementation as well. So we look into the patient's rights and education. So there's not much of a change, but then a lot of emphasis given towards how do you report the violation of the patient, and then also on the family member counseling as well by a multidisciplinary team. It is just no more a primary physician who's providing counseling, but also it has got to be the multidisciplinary team members. So it is just not that simple rights and responsibility displayed, but then emphasis is more towards patient education. So as and when, wherever, at whatever stages of care management or a care delivery process, the emphasis in an organization should be more towards patient education as well. So that is what is just being which is emphasized in the 5th edition. So along with that, one more point is on the patient feedback system. Patient feedback system should be comprehensive, again, more focused towards an experience. So hence in the OPD area and the IPD area, you have a different feedback format to capture the experience and just not as a questionnaire. We look at the important chapter that's on the hospital infection control. Needless to say that we have just been, dictated and we have just been following, and then we are working by adhering on all the infection control protocols ever since the pandemic has alerted us in a big, big way. So yes, we have an infection control program. So we need to review this using an assessment tool. So organization, apart from just preparing, we will have some kind of a monitoring protocol, which will guide us to relook into the infection control program and accordingly amend it. So the community awareness on infection control practices through educative tools needs to be demonstrated. And then the community outbreaks, we need to, again, the management will participate at times of community outbreaks. And this will involve coordination with the external agency, call it notification and things like that. So we are into practice of all of this. The antibiotic stewardship program also should aim towards improving the appropriate and necessary antibiotic use. Sorry about that interruption. So, and then again, we move to the next objective element, which is on the 4B, which talks about how are you reducing the risk of infection whenever there is an implementation of either a construction or renovation works which needs to happen. Simply, an organization should have a system wherein they will list down the plan, and the plan need to be approved by the infection control committee before you take up of any renovation works, with a focus to reduce the risk of infection. The surveillance activities is again emphasized more. The surveillance can be an active surveillance or a passive surveillance. So whenever you're doing this surveillance, you capture the data, and these data need to be analyzed, more focused towards appropriate corrective actions and a preventive action. And the last objective element, which is just brought out in this presentation, is so far we did look into what the organization will just be preparing towards infection control practices. But then there is this standard which talks more focusing towards reducing the hospital-acquired infection to the staff. So to that much an extent, yes, you look into the occupational health and safety, the immunization policy, the work restrictions for staff with transmissible diseases, blood and body fluids exposure. So you actually list down where all, what are the high-risk areas or the high-risk departments where all of these transmissible diseases can be encountered. And then you define some system practices. It can be to an extent wherein you are doing some kind of a facility planning as well. Simply example, in the clinical lab, you have your eye wash area and things like that. And then at the various departments, you have all your easy sterile zones wherein you just go by and clean up yourself. So all of these practices should be, it's apart from your infrastructure, your systems and practices, and your consumables, your PPEs and many of the things needs to be in place, all focused towards reducing the hospital-acquired infection to the staff, which is emphasized more in HIC 8 standard. The next 5 chapters is talking about we know it good, that it's organization-centric chapters. And here, looking into the PSQ, simply we indicated previously also, the CQI has become PSQ, emphasizing more on the patient safety and the cultural improvement. So the measurable indicators, in our 4th edition, we had this clinical indicators, a list of indicators against clinical, and then managerial indicators. So in the 5th edition, what has happened is it's beautifully just clubbed it into something on the diagnostic services. The organization is given the leverage to, based on the organization's scope of services, to list down the indicators which they intend to monitor, which they intend to measure and monitor, and also just going for improvement protocols. So the 5th edition standards are clubbed as something on the assessment and the diagnostic activities. And then it is also clubbed under your patient safety and quality. And then it's against on the infection control practices. So all of these clubbing indications and the managerial indicators, which is mostly on your utilization rate and your patient satisfaction, employee satisfaction, all of those indicators. So the organization has the leverage to define the indicators, and the standards in the 5th edition will help you out to club it appropriately. And then you demonstrate these indicators towards your monitoring protocols as well. So in the PSQ chapter, because the emphasis is more on the patient safety, we have this 2 designated people who needs to be there. The one is the clinical safety officer and the patient safety officer. So the clinical aspects of the patient safety program should be monitored, especially as something on the medication management or your infection control practices, which can just be looked into by the clinical safety officer. He will take over on that. So hence, an HCO needs to have a designated personnel against these roles. then all of these data, whatever we analyze, it should be more of a proactive analysis towards safety and identified risks. And we also have in a new addition into the PSQ chapter is an objective element which talks about the patient reported outcome measures. In short, it's called as PROM. So what is simply this means that we need to emphasize, this objective element is just trying to emphasize that there needs to be a better communication and a decision-making process between the doctors and the patient in the complete care delivery process. So to that much an extent that the patient, whenever he's just like undergoing through a care management, whether it is its quality of life or his symptoms or his clinical signs. Now with COVID, we also see that all the vital signs needs to be monitored, and it's just like more of telemedicines and patients are being monitored, asked to monitor at home quarantine, and then you just like get an alert indications and you go by. So hence to that much an extent, you need to capture, there has to be a system in place wherein we know what to capture as indicators towards building up a better communication. And it just does not stop there, and how you take it towards a decision making towards continuity of care as care management as well. So this is again a new addition which is just come by in the PSQ chapter in the 5th edition. So you have your analytical, statistical and managerial tools, which only helps you to analyze your data better. Your analytical tools can just be your various charts, your pie charts, your Pareto charts, and all of those. Your statisticals can be your sampling protocols, what you intend to, based on the data, what you capture. You can just either adopt a statistical, management tools. And then the managerial tools is nothing but your PDSA cycle or your FMEA cycle, FMEA methodologies on how you just like look into adapting these tools. You also have a clinical audit. Clinical audit is again one of the quality improvement measure. So what is again conveyed in the 5th edition is that every department will do at least one clinical audit per year. And this clinical audit needs to be either against disease base or a condition base, or on a process base, either retrospective or prospective data. But it has to be a good report wherein you define your inclusions, exclusions, you define your problem, you define your topic, have your inclusions, exclusions well defined, you have your data collection, you go through this complete thing on how you screen the data and how you just like capture, do an analysis. And most important is, since we're calling it as a quality improvement tool, you need to definitely provide recommendations for further implementation. So hence, clinical audit also just takes up a greater emphasis in the 5th edition. So then again, we also have to develop a patient safety culture and incorporate staff feedback system. So there's a lot of interactive practices which we need to be inculcating in the 5th edition and which needs to be again demonstrated. The various, and then again, the incident report and the sentinel event, you should define either you define a protocol and you implement it and also use it for your regular training. And this needs to be well captured against a standard format so that it becomes easy for implementation. So then again, or anything on quality, patient safety and quality improvement, it's got to be a proactive system. So any identify risk, you have your risk management program. So you incorporate this as you need to include this into your risk management program as well. Then you have your ROM chapter. ROM chapter simply says the role RRA, that's a role, responsibility and authority at the management level, right from the board of directors needs to be well defined. It's just not only the role, the responsibility and the authority level needs to be well in place so that the functional hierarchy gets defined right from the management level, right from the board level. Then you have your ethical management framework. Again, the fifth edition emphasizes more on the ethical management framework. The ethical management framework could be to cover up the patient, the employees, the operational processes, and also the research activities. So this framework is a policy which the HCO will define and it will adhere to. The competency of the leader and the operational capacities people, like the nursing head, the HR head, the medical head, all this needs to be, it is just not the personal matrix what we are looking into, it is at the organization level a competency matrix which will be developed and you are just going to demonstrate that. Then the change management, that also needs to be put across as a policy statement and a work instruction. It could be from an operational viewpoint or a financial or a department level either a new equipment coming by or a new leadership coming by or an additional scope, whatever just happens, a change management process needs to be well planned for easy implementation so that you don't go through too many error phases while in operations. So it simply says the management should ensure the quality improvement, the risk management, and the strategic plan are well integrated in its giving directions for the operational activities. The next chapter is on facility management and safety. Here, the emphasis is more on the disabled, differently abled category of patients who come by. So it should be demonstrated across all various settings also. It's just not only the toilet facilities, but then how easy or how friendly you're ensuring. Call it both in terms of your signages and your terms of directions, your information, your education, whatever signages you're using, that should be made more friendly to the differently abled category of people as well. And that the organization should be, it should be very much visible. Risk assessment, that across, especially during construction renovation, needs to be well thought. And you ensure the safety of your patients, employees, the environment needs to be well prepared. Both for new hospitals, why we emphasize on the new hospitals is it needs to be incorporated right from your design stage itself. The electrical safety audit, yes, needs to be in place. And most important is your service continuity. Any time of emergency, you're in the seventh, in FMS 7, it emphasizes on the fire and the non-fire emergencies. But any encounter, any disaster encountered, we need to demonstrate a service continuity. So a plan should be well in place. The HRM chapter talks about the contingency plan, what you're going to be having to, whether to address the shortage of staff, either on a short-term basis, long-term basis. But the emphasis is again more that whomever you want to, especially the locum people, needs to have the same kind of an orientation and the on-job training activities also. So you ensure that they are well prepared to take up right from your documentation to your implementation practices. The organization structure, which should just be very simple, not add too much of a matrix into it. So which should just like easily demonstrate a relationship at a functional level. The exit interview outcomes needs to again become a tool to improve your HR practices. That needs to be. So you need to have an exit interview form, which you capture, and the feedback is again. So how you take it across through your committee meetings and again into an amendment in the policy or a protocol needs to be well demonstrated. The code of conduct, yes, should be there. The HRM chapter emphasizes more on the training. In the 4th chapter, we did see that, there was always this objective element that staffs are made well aware of this and things like that. Now in the 5th edition, it's beautifully brought under various headings. Whether it's induction, you have your list of induction training programs, activities, what is happening. You have your on-job training activities, what is happening. And you also have a safety and a quality specific training activities. And then your professional development training activities. And then governing all of this is how a policy document on training activity itself. That you have a plan, you have your training materials, you have a trainer, you have your internal, external training activities, which is happening right across evaluation and taking a feedback as well. So all of this is covered under training and it's beautifully brought out well for easy implementation and also for monitoring. The staff welfare is given a lot of importance, including if you sustain a work-related injuries, how are you going to just like take it and then work against it? Then in the HRM chapter, there is also a mention on workplace violence. So you work it out against your code. And then there is inclusions on the paraclinical staff and the credentials and the privileging. So paraclinical staffs are all your technicians, your pharmacists, your counselors, and your nutrition specialists, your physiotherapists, all of these people. We need to have a credentials and privileging, which needs to be well spelled out before they give their services. Then the last chapter is information management system. Yes, information management system is all about data management. So you have your process well defined for data integration and data dissemination. So that is how you will just look by. The accuracy to the various stakeholders, accuracy in the data is what needs to be looked into. So you have a system wherein you don't have all of this, the loose ends, especially when you're capturing and disseminating the data. So the medical record, there's a lot of emphasis given on the medical record system. So how you just maintain your medical record and the retention of the documents is what is emphasized in the IMS chapter. Now moving on quickly to the we looked into the various changes or the new additions, what is come by across various chapters. So now we look into quickly on the organization preparedness. So NABH is basically a top-down approach. Management committee needs to be well, visible and committed. We should be able to look through it, because it's the management commitment which just takes the leadership is what just defines the rest of the activities when we are going in through this journey. So because there is budgeting also happening there, the organization scope of services, the statutory regulatory requirements, all of this is a management responsibility. The clarity on the 5th edition should be known. The language interpretation as should, could, appropriate should be well understood for easy implementation. When we say written guidance in the 5th edition, it simply means that any documents, whatever you prepare, either your manual or your work instructions or the SOPs, or any of the documents should lead more towards implementation. Then you have your various hospital committees, which you form, including your quality steering committee. You have your documentations and then implementation. This is how an organization should start preparing towards going in for either adoption or migration. Then the quality departments, the major responsibility, this department would be kind of spearheading the complete accreditation activities. So hence you have a quality head or a manager. Then you have your quality coordinators, the chapter owners, the department in charge. So you have all of these people who take up the responsibility towards not only in documentations, but also in implementation and monitoring. So you also have a quality steering committee, which will be formed by representatives across your clinical department, your diagnostics, your facility, and the support services. So quality department also remain custodian for all the documents, because you need to have a good document control system. So apart from the respective department in charge of the owners, the quality department still holds on towards ensuring it's the right, updated, and the current document, which is just in place for implementation. So you monitor your system. The quality department major responsibility is to monitor the system and the process implementation, and then you take it across through a CAPA based on the various identified risk, the feedback system, the inputs from the various committees, what you gather, the internal and external audit system, the risk assessment, surveillance reports, and you have your department performance and your clinical managerial indicators. So all of these activities is what you would be doing on a regular basis. And this is where the quality department looks through all of this towards taking it for ensuring a corrective actions or a preventive actions is implemented and monitored. So it's more like a journey how the quality department would be handholding across various functions. So apart from that, they also will be in charge of an internal audit. They do a self-assessment against a self-assessment toolkit, and then monitor the various training activities. So quickly looking into the categorization of objective elements, we know it good that it's 651 objective elements in the 5th edition, distributed against core, commitment, achievement, and excellence against the various numbers. Then the compliance rate for accreditation. So we just quickly look into this, that at the stage of final assessment, when the organization is demonstrating commitment for accreditation, you need to have a compliance rate of more than 80%. And then the core elements are something that it is mandatory. It's because it's directly linked to the safety aspects. So the core element is 102, and then you have your commitment objective elements as 459. So put together, when you have to demonstrate yourself during the final assessment, you need to adhere to 561 objective elements with more than 80% compliance rate. Achievement, yes, that is at the surveillance audit time. You add up the achievement objective elements. So this 561 is already there with you, which I have demonstrated. So during the surveillance audit, you add up another 60 respective objective element, putting across to 621 objective elements compliance rate. Then when you reach a stage at reaccreditation, you take the 621, plus you add up the excellent objective elements category, that's about 30, totaling at up to 651 objective elements compliance rate. Whenever an HCO identifies a particular objective element as not applicable, you place it on record, and this will go to the accreditation body. And the accreditation body, when it finally decides to come in for an assessment, they will look into this point and then make it final whether it is still applicable or not applicable. Then your self-assessment on audit preparedness. So simply, as we indicated, the scoring pattern 1 to 5 from non-compliance to poor, partial, good, and full compliance. We have to just look into the sample size. If it is none or less than 20% of the sample size meeting to the requirement of objective element, then it's simply the score of 1, which simply indicates non-compliance. So that's how you go about less than 20 here, and a scoring of 2 indicates 21 to 40% sample size. I guess it was okay. The partial compliance, again, 41 to 60. A good compliance is 41 to 60 here. And then full compliance is 81 to 100. So it's a typo error, 60 to 80 there. Then the accreditation process and cycle. The self-assessment organization, when it is just ready, they do a self-assessment using a self-assessment toolkit. A scoring is all done in the similar pattern, the way it would be looked upon by an external auditor. Then you file your application online. Then you get on towards calling in for a pre-assessment. Then there's a final assessment wherein you are demonstrating commitment and you get an accreditation certificate, which will be valid for 4 years. Then between 21 and 24 months of your accreditation is when the surveillance audit takes place and you're demonstrating your achievement objective elements. The recertification audit process, which is at least 6 months prior to the accreditation, your 4 years validity period, that's when you will indicate, and then you will ensure that your excellence objective elements, the excellence category of objective elements, is also met during your recertification audit process. So then there are some accreditation decision criteria. It simply goes to say that, yes, either greater than or equal to 80% compliance rate is what you need to demonstrate at various stages, whether it is final assessment, surveillance, and recertification. Then this is the commitment. This is the core. This is invariably, yes, you need to be there. The score level, this is what it is. At the achievement level, we don't look into, when we are doing a surveillance audit, we assume that your core and the commitment objective elements are very much there. So we only look into this. So then you go on to the excellence. So at all places, these are the scoring pattern, which is more than or greater than or equal to a score of 4 at individual chapter or objective element level. And then, yes, wherever you encounter a scoring of less than 3, you need to just demonstrate in your subsequent audits as well. So these are towards the decisions. Then coming on to a summary slide on the 5th edition, it simply says that quality is a journey. It needs to be considered as a continual journey. So an organization, a healthcare organization, should demonstrate to just not meet compliance, but commitment as well. And this compliance should be more an objective manner. So what do we do? How do we just place an indication in the objective manner? Because the audit usually takes place whenever an external auditor is there in place. You demonstrate your compliance either through inspection or interview, or by just showcasing your documents or records. Whatever you do out here in an objective manner, it simply indicates that whatever you demonstrate needs to be consistently met. And that is how the 5th edition is emphasizing more on. So when you are in your consistent practice, you demonstrate a quality continual improvement through the accreditation cycle. That is from your commitment level to your achievement level to your excellence level. And that simply ensures, it's simply taking you to a journey of assurance. In all this process, what you're actually looking into is the patient safety and the quality care in services remains integral in the performance across hospital function. And this simply needs to be demonstrated, ensuring transparency. We also know that quality, every employee participates as a stakeholder in the quality journey, and this should be visible, and which is just ensuring accountability. So the 5th edition is mostly touching base on all of this. And the outcome of all of this will simply be a system-driven organization. It's no more a person-dependent or a protocol-dependent. A protocol invariably will talk about a system, and hence it should drive towards a system-driven organization. So that is where the NABH 5th edition is trying to emphasize more on. So then, before I say thank you to you all, let me also say that, since it says MedLearn NABH Learning e-modules, let me say that I did look through the MedLearn e-learning modules. So it's beautifully brought by. There are more than, I think Dr. Renu can correct me, there are more than 60 hours of learning academic content into it. Not academic content, operational content. So the way these course materials are also developed is each of the standards is called a course. And each course has got a course objective. And then each of the objective elements is emphasized more in detail towards giving a description, and an evidence to compliance pointers against each of the objective element is brought out. So it's just not an indication, but also it will take you, when you're just going through this course module, it will make you feel more into an implementation or operational level. The case scenarios and the assessment, what you have on the e-learning module, will make you feel more like an operational activity. So hence, to that much an extent, yes, these learning modules does make things, a self-learning, more operationally effective. So that is where I wanted to just end my talk. And I once again say thank you to you all for the patient hearing. And I only hope that I have not run short of time. So let me stop sharing. And I will hand it over to Dr. Renu for Q&A. If there's anything that I can just I'm ready to take up the question answer session.
Yeah, thank you, Dr. Madhu, for a very informative session. I'm sure our audience would take the learnings from this webinar and implement it as their organization prepares for the 5th edition. So I'll start with the first question. Is there a requirement to prepare new sets of manuals when a healthcare organization goes in for migration to 5th edition?
Okay, now that you're talking about migration, no. Actually, all the documents, if you just look through, we need to just, the objective elements are clearly defined as what is going at different categorization. So the quality department of the organization, when they're looking into the manual, they need not prepare new. They need to only ensure that these manuals can be easily, the return can be easily implementable. So you only look at those sections where it is kind of, bringing in ambiguity. You take away that ambiguity and you just try to just bring in more a systematic approach towards how you want it to be implemented as well. And to that much an extent, in the first edition, the NABH manual provides you how a manual should look by. The first page is always have this document revision indicate, a page which is for document revision. So you capture those things, which page number, which section of your manual is going in for revision. So you just put in there, and that itself should just be good enough. So you need not actually go in towards revising the manual. You can revise those sections, but then have it there and give your justification that initially you had it more subjective and now you're going to be having it objective in compliance to the 5th edition. So if you just ensure that is done, I think we are safe there.
Thanks, Dr. Madhu. Then another question, what is the procedure to be followed if patient is being discharged and has narcotic tablets to return?
Yeah. So here it is just especially on the narcotics, what happens is there's a regulatory compliance is what we need to adhere to. So hence, to that much an extent, it needs to be captured. There's a checklist what we intend to follow on how it is, it's against everything has to be evidence, right from your prescription, and prescription should have a patient identifier. So you will just capture all of these informations and then ensure that for what purpose, who is the care provider who is signing it. So right from the dispensing to how it was monitored and how it should just be returned, against the pharmacy also accepting it based on the defined criteria. I did also mention that there's a defined criteria, what can be taken back and what cannot be taken back. So, but here with narcotics, there is regulatory compliance also we need to document. So to that much an extent, yes, against a checklist, we need to capture those information and it can still be worked out.
Next question, Dr. Madhu, what are the essential functions and limitations of clinical safety officer? How is it different from patient safety officer?
Okay, initially in the 4th edition, it was on a broad line that we have a patient safety manual and the patient safety officer who was just taking care of. But then what we did encounter is, because this 5th edition is talking about patient safety and quality improvement, there's a lot of focus given in there. So to that much an extent, we thought that the patient safety officer is more, it is getting more generalized. So the clinical aspects in the safety management is taken over by the clinical safety officer. So there has to be a designated person with a defined role to only look into the clinical aspects on the safety things. So the clinical aspects, for example, it can be on your medication management, your infection control, surgical save, SSI, the surgical site infection rate and things like that. So your antibiotic. So on the clinical aspects of the patient is what needs to be looked into. So there has to be a specific document which will clearly elaborate who takes up a clinical safety aspects and what would be his role, the role and the responsibilities for him, and then how he monitors, how he takes up the various activities, the clinical activities which will be taken through the process.
Okay. Dr. Madhu, how to calculate acuity-based nursing care and document? This is one of the questions from the audience.
Actually, what happens is we have some best standards, what is practice, the kind of ratios, what you need to. We look at this in two aspects. One, it's a new hospital which is just coming by. So how do you define? And then there is an existing hospital. Then how do you plan up your duty roster? So organization, the HCO, based on the services, what it offers, and then kind of facility mix, what it's got. When I say facility mix, your ICU, your HDU, your operation theater, your, your IPD sections at various things. including your isolation areas now all the more with pandemic coming by. So what you do actually is you have your list of facilities well defined. And then when you have your list of facilities, we know that the nursing staffs work round the clock. And hence the right proposition of the various categories of staff. And these categories of staff are your senior nurses and your staff nurses and your nurses training and things like that. We are only talking about those categories of nurses who are in direct contact with the patient care, not the supervisory categories. So when you have these numbers, it's more like an apple shape. You have a short number of senior staffs, you have a good number of nursing staff, and then you have your training staffs as well. So when you have this kind of a distribution, you again you look into the number, and while you're looking into the number, same time you look into the competency of these people. So, and then ensure that these competency of the nurses against the numbers needs to be distributed across the facilities. So a good planning is what is needed, but invariably what we see is extensive internal training should keep happening so that the competency of the nurses or the capacity building should take place, so that, because we cannot be all the time having nurse A to be just like only there, to be in ICU and things like that. So whenever there is a possibility, of course, ICU is not a right example to be picking by a clinical condition patient, HDU or any of the IP areas. If you encounter there is a patient with a clinical condition, which is more closer to towards an HDU management or an ICU management, but you're still managing here, then you ensure your competency of the nurses there to cover up for that patient. And always, whenever we do this, we ensure it's a round-the-clock management. So for a new hospital, it goes on in a different way, that you have your recruitment planning, which will just guide you through when and how you will just take by pre-commissioning, commissioning, and the post-commissioning again. And with all of this, we will also look through on the contingency plan on a long-term, short-term, and things like that. So a good, and nurses, mind you, Dr. it's just like more than 50% of your hospital staff strength is comprised by the nurses. So hence, to that much an extent, you need to really have a good nursing plan as well. Your recruitment plan and the nursing plan should just be well in place when we are addressing into this compliance.
Okay. Then next question, is there any relaxation because of COVID management protocols? Is there any relaxation at infrastructure specifications?
No, actually, there will not be any relaxation because, you are trying to just do some kind of an adaptations and things like that. Initially, all the screening, we saw it and we were with it, that we did see that, a lot of the patient functional flow, only keeping the infection control practices, we had to, organization was not very, none of us were prepared for this pandemic, but then we had to just go through this process. And while going through this process, we learned a lot. So hence, we are only ensuring that, yes, there is a requirement to do infrastructure adaptation, but keep in mind the infection control practices and the safety practices. While you're doing the infection control and the safety practices, keep in mind the care delivery process also. So when I say quality care delivery process, you just ensure that equal amount of easiness given to the patient. So the infrastructure should be made adaptable for the scenario, but not compromising on the infection control practices and the quality care delivery. Safety, key bone there.
Okay. Next question, due to COVID, there are some virtual assessments that are being done by external auditors. So can you tell us how organizations need to prepare for online assessments? Okay,
what's happening is at the QC, at the NABH body also, like with this pandemic, there are various modes in which an assessment is taking place. One, it can just be a hybrid type of assessment also, like one auditor is there on site, and depending on everything is just like decided based on the application, depending on the organization's scope of services, the size, and the various, when I say organization scope of services, it's the quaternary care or the tertiary care and the specialties, what facilities and the services, what gets in there. So when an application goes by, then the NABH body will look through the application and then plan up the audit process. And when it is planning up, they will also decide whether it can just be done with only online or whether it can just be a hybrid type of a model with COVID. But that one person will be on site and the rest of the auditors can be offline as well, off site as well. So during this process, this is how a structuring can happen. But having said this, what is just being changed is at the NABH body, they've just been, everybody is going through this learning phase. So as this NABH, the application process also, when you're filing the application, So there's a lot of things which is just captured, on how we have to demonstrate. Initially, it was just like we were just getting ready. The alters used to come by and it used to be a smooth journey. Now, at an NABH body also, this filing process is also made very systematic in nature. That, what kind of documents goes in at which category, etc., etc. It's a beautiful Excel sheet with Excel file with various sheets, which is again talking about functionalities. So all from organization preparedness perspective, you are just ready, you're filing, just be ready for the assessment process, however it comes by, because the online application process is educating you on how you have to demonstrate your compliances, whether in terms of uploading the documents, uploading the samples, and etc., etc. So that is what will happen in stage 1. And during the process, the technical team at NABH, they will be scrutinizing your documents. So during that process, they will simply not say that, okay, non-compliant. No, they will not do so. They understand, the process of, because we are online, it's all submission and maybe we've missed out. So there's going to be a more and more communications between the technical team there and with the quality representative at the organization. So at various levels, we will be uploading certain documents. So it's just not one upload. Of course, we do it in a very disciplined way that we will ensure all is submitted. But during the scrutinizing process at the back end, at the technical committee there, they will put across certain concerns or whatever needs to be supported. So to that much an extent, the organization will prepare to submit or to demonstrate what is needed. So once when all of, a lot of photographs, the live photographs and many things like that, the pathway and all of that needs to be, the patient flow, all that needs to be demonstrated. And then that's how you just submit this thing there. And at the time of audit, of course, there's a checklist of information what the NABH body provides you on how you are just needs to demonstrate. So they will just give you, it's a complete checklist, which is very live in nature, that you will have your internet facilities of this kind, your video coverage like this. And then they will say that one IT person needs to be on the ground and you just take it across through, just ensuring compliance. So making it as much as possible as online, on-site as well. So this is how it goes by. So that's in short on how an organization can prepare. But it's very self-educating. So it's not too much of a concern or a high level of preparedness needed. You go with the flow. There is a technical committee which is just looking into before they can submit it to an accreditation committee, which is actually being presented there.
Dr. Madhu, one question related to training. Due to COVID, some trainings are happening online. So will these training hours be considered during audit?
Yes, the training, basically now, but we know it good that, it's most of it is just online training, which is just happening. So what happens usually is that as long as your training material, your trainer, the trainee details are well captured, along with the training evaluation practices, how did you evaluate the training, the materials. So if you follow the training calendar, the training activities, right from your planning stage, where the training was given, whether it was just using some presentations or how was it given, and things like that, well captured, along with feedback from the trainees and your evaluation process. So if you demonstrate all of this, which is components of the training activities, it will still be considered for compliance, for demonstration and compliance further.
Okay. Another question, ensuring quality is a challenge for hospitals, and most of TPA and CGHS have approved a limit of consumables. As a result, most of the hospitals are using used PPE and syringes for patient. Is there any cost-effective solution for syringes or couch rolls and soaking sheets?
Actually, the thing is, this is definitely becoming an issue, but then what we need to emphasize is that to a largest extent possible, because this is going towards an external agency activities as well. But ideally speaking, no compromise on the infection control practices at all, especially on the syringes and things like that. There is absolutely no compromise. So we need to just prepare by ourselves in how we just go by. So should not be that we don't compromise to a largest extent possible. But then we are in the learning phases. So we will just ensure that we learn good in terms of how we ensure our backup support system. So, towards ensuring the same services is given while we have all of these shortages as well. Good vendor management, your supply chain management needs to all be in place. So we have learned a lot. So I think we should just keep in mind that we will not compromise in the quality of services, especially on the infection control practices.
Okay. And Dr. Madhu, I mean, the questions are coming in, but in the interest of time, one last question. Can you brief on reconciliation of medications?
Reconciliation of medication, that's again, it just goes on into a practice on a checklist. So whenever a patient gets admitted, during your initial the medication advice, whatever you give, so the patient would be taking some medicines at home and things like that, or as a chronic patient, so would be taking it. So, and then you just get yourself admitted, and then there is a list of medication order which is just shown to you. So what you actually do is you just get into, along with your care provider, your primary physician, on how you want to just reconcile based on the present clinical condition and the present clinical status. So it goes on towards defining a care plan. So as you're defining a care plan, the reconciliation is a part of a care plan demonstration itself. So that will be an activity which will be performed while you are deriving a care plan of a patient. And this will be taken across towards your medication management protocols as well.
Thanks, Dr. Madhu, for answering all the questions very patiently. And thank you to all our audience for their wonderful participation.
No, I'll be more there. I'm so sorry to interrupt you, Dr. Renu. I'll be more than glad if there are many questions coming by. Let it just be posted to me on a mail. So it'll be my pleasure to just answer them.
Yeah, or they can reach out to us as well, right? They have our email ID. We can answer them back. Richa, also someone asked from the audience that can they get the recording of it?
Yes, Varun. So we
Not sure.
will be
Just sort of
posting the recorded session on our YouTube channel of Medlearn shortly, I think in a day or two.
And how can they access? They
yes, it's an open access. They can just subscribe to the channel and look at all the videos that are available on Medlearn.
Yeah. And also before we say, someone asked about the training on NABH through online platform, right? And that's one of the problem statement which we are solving through Medlearn platform, right? From delivery of those modules on a digital platform, and also from the compliance perspective, how to show those audit trail during the assessments. Yes, I think we are solving those problems as well. So please do reach out to us. You have those, credentials, right? Email ID.
Just posted our email ID in the chat box.
Yeah.
So if there are any queries on Medlearn, please feel free to write to us.
Yeah.
And thank you so much for attending the webinar. Thank you so much, Dr. Madhu. Thank you, Dr. Renu. Thanks, Varun.
Let me also extend my sincere thanks to everybody, and thanks to Medlearn team for just like making it so smooth going, and thanks to Macula team which has helped me to prepare this presentation.
Yeah.
So thanks to all of you.
Yeah, from our side as well.
And most important, the participants.
Yes.
Thanks for the patient hearing.
Thank you so much.
Thank you so much.
Bye all of you.